Welcome everyone. This is Dr. Sharad Jaitly. Thank you for watching, learning, and sharing on MuniMeterHealth.com, your favorite website, which is dedicated in educating you about the human heart and its illnesses. Once again, welcome to MuniMeterHealth.com on Facebook and YouTube. Those are the two channels where we feature constantly. Hopefully, you are signed on both. Without any further ado, I do want to acknowledge my appreciation, deepest appreciation for the enthusiastic interest and support you have shown in my cause of spreading this education freely to all. Thank you again for watching MuniMeterHealth.com. Without any further ado, and let's delve into this subject matter, and the matter of the subject today being pharmacological stress testing. What is pharmacological stress testing? Well, it is a form of stress test where somebody is not able to perform an exercise routine stress test. Pharmacological stress testing is normally combined with the nuclear imaging. Remember that. So it has to be either either a technetium-99 based study, or it could be a PET study as well. So, but invariably, it's normally a SPECT study as we commonly use. The products like tetraphosphine or system-EB. These are the two nuclear agents one can use. But that's for the tagging later on. We'll talk about it in a separate video. But pharmacological stress testing normally implies two groups of drugs. The first group of drug is vasodilators, and the second group of drug that I have is the demand drugs, I call them. And the typical prototype for demand is dobutamine. Now, dobutamine, as you know, is a very powerful very powerful beta 1, beta 2, and alpha 1 receptor and agonist. So it's an adrenergic agonist, and it has varying effects on low doses, intermediate doses, and on high doses as well. So on lower doses, for instance, it can cause systolic blood pressure rise. And intermediate doses, it can drop the diastolic blood pressure a little bit while the systolic blood pressure continues to rise. And in the higher doses, the heart rate would start to increase, and as a result, there will be increased contractility also. So the oxygen demand will rather increase precipitously here in the higher doses. This is where I think some arrhythmias can also be cited, especially the VPCs can develop, or even the non-sustained VTs can develop. Sometimes your patients can have SVTs. Now remember, all these arrhythmias can be reversed by giving IV blockade, beta blockade, if you will. So IV metoprolol, if you will, like the Lopressor, or you could use IV esmolol to circumvent these side effects should they be a problem. But normally dobutamine is extremely short acting, roughly about 4 to 6 minutes, and the IV infusion, once it's stopped, at that point the action is all dissipated, so it should not be an issue. Normally it is given by, as I said, by an IV infusion where the person is laying on the table. So it says 0 minute it starts, and normally the increment is every 3 minutes, 5, 10, 15, 20, and so on and so forth. It goes up to 40 mics, if you will, per kilo per minute. So it starts with 5, and then you go up to 10, you go up to 15, and then 20, and then 40. Normally the side effects will begin somewhere here between 20 and 25. And the infusion, once you have reached the maximal dose, that's the time when you want to inject the technetium, for instance. The technetium-99 or the radioisotope is injected at that point. That is the crucial time when you want to inject. Now remember, systolic blood pressure times the heart rate is the double product, and that's what you really want to achieve all the time, even while you're doing an exercise stress testing. So this is the beauty about this demand drug, that you can actually increase the systolic blood pressure as well as the heart rate, and therefore develop a good double product, almost I would say simulating the exercise stress testing. Not quite, but still as close, and can result and can give you good results to define whether there is ischemia, whether it is profound ischemia, or whether it is totally normal coronaries. So these are some of the features of the dobutamine stress testings. As I said, starting with 5 mics, going up to 40 mics per kilo per minute. These are demand drugs, obviously, and the other drug that's commonly used is also milrinone, but that's not as popular as dobutamine. Dobutamine is the way to go for the demand drugs. Now, in the vasodilator group, you have three drugs again. One, the first group is the percentin group, and here it is also called dipyridamole, as you know, dipyridamole. And this drug is actually used in a setting where the dosage is about 140 micrograms per kilo per minute. And the same thing is for the adenosine. That's the other drug. Adenosine, as you know, is a naturally occurring substance. We have it within our endothelial cells, we have it within smooth cells, within the vasculature cells, etc. So adenosine is present in almost every cell, and the action is on A1 and A2 receptors. That's how adenosine works. And when you're giving it as an IV infusion at the same dose, it's the same dose, the action is the following. Now, the way it works is it basically causes a coronary steal mechanism. And the coronary steal I'd like to show you here, it works like this. Say if this was the vessel that was supplying, and then it divides into two right here. The coronary steal will occur from the stenosed vessel. The blood flow will all go into the... So in other words, if the vasodilators were to work on these vessels, the normal vessels will vasodilate, whereas the stenosed vessels will not. So normal vessels vasodilate, stenosed vessels they don't, and as a result there is a steal mechanism, we call it. And that steal phenomenon, that's the principle of these vasodilated drugs. So the coronary steal that occurs from the abnormal myocardial bed, if you will, to the normal bed, resulting into increased vasodilatation and therefore causing a relative ischemia. That relative ischemia will be seen when you tag them with the nuclear scan. So how do you do the protocol? The protocol is done the following way. Here the person is laying on the table. At 0 minutes the infusion starts. Then remember, the infusion completes at 4 minutes. So at 4 minutes it completes. Percentin is, remember, percentin continues until 7 minutes, when at the 7th minute actually you give your technetium 99. So technetium 99 is injected at the 7th minute, whereas this is for percentin. But for adenosine, it is injected at the 3rd minute. So for adenosine, it is injected at the 3rd minute. Why? Because it's a very, very short-acting drug, and as the levels, they start increasing within the 1st, 2nd, 3rd minute, that's the time when you want to capture that quote-unquote picture of this coronary steal, if you will, at the 3rd minute, and therefore you inject your technetium 99 here when you're doing the adenosine. Whereas for percentin, if you're doing the percentin protocol, 4 minutes, obviously the infusion is completed, but you wait out for 3 more minutes and then inject the technetium 99, because that's where the peak will occur. So essentially these protocols are meant to elicit coronary ischemia, obviously in patients who cannot exercise. So there are indications for pharmacological stress testing. Patients who cannot exercise, for instance, that's one. Patients who are pre-operatively being evaluated and they are in no shape to really exercise. For instance, they could be elderly, they could be frail, they could be deconditioned. They may have an abnormal EKG. A left bundle branch is a very, very common indication to do a pharmacological stress test, because exercise stress testing will be useless because left bundle branch makes it absolutely impossible to read ischemia. And likewise, it's true a pacemaker. If somebody has a pacemaker, you're better off using, because the heart rate is not going to go up, and plus the EKG will be abnormal to begin with. So again, it's uninterpretable. So whenever the EKG stress test or exercise stress test is not performable or is not readable, then at that point you might want to do a pharmacological stress test. But in general, we always prefer exercise stress test first. But if you're not able to perform, then you do a pharmacological stress test. Now, amongst the pharmacological stress tests, the vasodilators are preferred rather than the demand, because of the demand. Dobutamine drug has a lot of side effects here, including the, like I said, the arrhythmias, the VPCs, the VTs, non-sustained VTs and SVTs, even though they could be all reversed by the IV blockading drugs. Just remember that. And again, the demand protocol on dobutamine lasts for 10 to 15 minutes because you start with the 5 mics and go up to 40 mics. Whereas the pharmacological vasodilator drugs, the persantine and adenosine, they're all completed in 4 minutes. So they are quick protocols. Adenosine is even quicker because obviously it's a short-acting drug, and as soon as the infusion is completed, the adenosine is out of the body. The only difference is, the minor variation is, when you're doing a persantine test, you inject at the 7 minutes, the radioisotope, whereas with adenosine, you inject it at the 3rd minute. And for dobutamine, you inject it only at the level where the double product is maximum or until the symptoms occur. So once the double product is established, that it is sufficient enough that you have reached the 85% of the, say, the maximum heart rate, for instance, then at that point you can inject the technetium-99, and that'll be the good, quote-unquote, photographic nuclear memory picture taken at the time when that injection is offered. So in a nutshell, I've discussed the pharmacological stress testing. The only contraindication, remember, for vasodilator drugs is asthma. Do not use it for asthma, and do not use when you have a high-grade AV block. If you have a high-grade AV block, do not use vasodilator drugs, please, because these are a no-no. These are contraindications. So asthma and high-grade AV block, one should not use because, one, they can precipitate an active asthma in these patients, and two, if they already have high-grade AV block, a 2nd-degree AV block, for instance, that can precipitate into a complete heart block and a sinus arrest can occur, or a cardiac arrest can occur. So just so that you know, these are the 2 contraindications. Third contraindication is also relative, that the patient is on persantine or dipyridamole for other reasons, say post-stroke or what have you, or a vasodilator drug being used for other reasons. So there also, obviously, it's not going to be of any use because now you give persantine infusion where somebody's already on persantine. It doesn't make sense to give that. Then you prefer dobutamine. So whenever you have asthmatic patient and patients not able to exercise, use the dobutamine. Now that'll be given on the boards, by the way. They'll give you a second two-step taught test question, and they'll define that the patient not able to exercise, and then we'll also say that, look, coronary ischemia needs to be assessed, but at the same time patient has hyperreactive airways or has had an episode within the past 6 months where he or she was admitted to the emergency room for asthma or was evaluated for a high-grade AV block through a Holt or EP study, etc. So they'll give you some clue that you may not be able to do a vasodilator drug pharmacological. Then in that case, just do a dobutamine stress test because that's the only choice that's available to assess coronary ischemia in those individuals. I thank you again, but remember, the vasodilator drugs, just peculiarly, they work by the coronary steal mechanism, as I've shown here, where there's a relative increased coronary blood flow in the normal bed as opposed to the stenosis or abnormal bed. So this way, relative ischemia can be seen on the nuclear imaging when somebody is performing the nuclear stress testing. I thank you for your interest. Keep watching MuniMeterHealth.com. Until then, so long. This is Dr. Sharad Jaitly. Thanks.